Good, I'm Jorge Alió. I work in Alicante, Spain. This is our clinic, and we are very much devoted to anterior segment surgery in general, but particularly in cataract surgery and refractive surgery. Obviously, refractive surgery is cataract surgery today, and refractive surgery uses lenses, and the topic of this presentation is about lenses. It's about precisely the new pentafocal diffractive lens of Hanita, which we have quite a long experience. We have first to consider that we are on the rise of lens surgery. The rise is related to many factors. One, we are operating the cataracts earlier. The second, we are using the dysfunctional lens syndrome as part of our armamentarium, because there is a moment around the middle 50s in which the natural lens of the eye is declining, and this decline can be improved with the use of a lens that is adequately chosen. This is the moment in which we are doing refractive surgery with intraocular lenses, and this trend that has been detected already by us, was published in Lancet, and in this paper, and Lancet is not an issue not to publish, really consolidate our opinion that we're dealing with a different moment, a moment in which there is a change of paradigm. Because the paradigm so far was to restore vision, to restore vision with cataract surgery, while the new paradigm is to restore quality of vision with spectacle independence, and improving the quality of the retinal image of the patient is the main issue involved in this improvement. So we are in a change in paradigm. This change in paradigm is the topic of this presentation as well. So in order to have successful outcomes today, you have to accomplish several points. The first is you have to have perfect surgery, and minimal invasive lens surgery is the one important topic today. You have to look to your surgery, you have to improve your outcomes, and you have to have good indication of what you are going to do. You need surgeons' wisdom and experience and knowledge about what the technology is offering to you today, and the target of your indication is to gain a quality of vision of the patients, emmetropia, and spectacle independence. In order to accomplish this, you need to substitute the natural lens of the eye by an adequate lens, and the topic of this presentation is one lens that I have found particularly useful in my choices about to get this goal, to get patient satisfaction, improving quality of vision, and improving the quality of life of our patients. It is true, and we have just had a course now about rid of lenses, that you can only guarantee spectacle independence for near with multifocal lenses. You cannot offer EDOF lenses today to gain spectacle independence for near. The EDOF lenses are for far or for intermediate, and so this is why we're moving more and more again to multifocal lenses, because at least in Europe and at least in our clinic in Spain, our patients want to read and want to read for near. In order to have an adequate process in terms of the outcome of the multifocal lenses, you know that we have to consider neuroadaptation. We don't have a multifocal brain, and we don't have multifocal vision until we implant the first time for the life of the patient with a multifocal lens. This is why whenever you're using multifocality, you have to deal with a neuroprocessing evolution in which you have to know how to deal with that. And the first step of neuroadaptation is have good quality in the retina of the image that you have for far. In other words, first step of neuroadaptation is have good vision and the retina, good quality of vision. This is a topic that involves this presentation. So what is about the Hanita intensity? Why this new pentafocal intraocular lenses has attracted my attention, and why I'm talking to you now? It's a pentafocal symmetric distribution of foci around the zero order. In other words, you have about the same before and after the focal point. You have a symmetric distribution, looking to have good near vision, not at the cost of bad far vision. In order to gain this, you have to maximize the light intensity on the optical design of the lens, and you have to be efficient in using the energy, in other words, the light that enters the eye. This is based in a patented profile that is dynamic light utilization algorithm. This is a complex algorithm in which you have a multi-loop concept between the destination and the source plane. I'm not going to go into details because this is much more the area of the engineers of the company, but you have to consider that in order to build up this lens, they have considered two things. One, the vision should be good for far and for near. That means you have to get a good retinal quality of image. But the second, you have to be efficient in gaining the spectral independence for far and near, and this is why this pentafocal design was fine. The lens has the performance of any lens. It is supplied in powers from 10 to 30 diopters. The optical design is the one that you have here. Is a diffractive multifocal lens with anterior surface spherical. The refractive index is 1.46, and the spherical aberration is negative, moderately negative, in order to have better depth of focus. The material is 25% hydrophilic, and you have the light filtration. That means you have a chromophore that is filtering the violet light, which is the one that you know is toxic for the retina. In other words, doesn't create this photoxia. It's not a yellow lens. So we have studied this lens. We have implanted in a consecutive study multicentrical in Miranza. Miranza is the largest network in Spain for ophthalmology, and we're part of Miranza. And we have evaluated in this multicentrical study the visual, refractive and optical data. Obviously, this is the main core of any study about intraocular lenses, but we have focused particularly 2 points. One is the retinal quality of image. That means how is the image in the retina that the lens provides, and the second, how is the feeling of the patient, because you can have 20/20 vision, but the patient might be not happy, and we have been trying especially to focus on the patient-reported outcomes, the PROMs, which are obviously the ones that matter to us, because from them comes the patient satisfaction or the patient dissatisfaction. This has been a clinical prospective open label single arm multicentrical study, and we did that in our centers in Alicante and Madrid. These are the variables that we have studied. The first 6 are the ones that are analyzed in every intraocular lens that we study, including ocular barometry. But I want to pay attention, especially in this presentation, the clinical optical quality of the retinal image, and I will explain to you how we measure that and patient-reported outcomes. So we had this technology in order to measure the patients. We had a sample size of 62 eyes of 31 patients, so it's a very significant number to analyze our outcomes. As you see, we went up to the 6-month follow-up, important because we like to have the patients after 3 and 6 months, especially because the neuroadaptation sometimes needs more time to happen, and the inclusion criteria was in all cases that we should have more than 18 years of age. We did bilateral cataract surgery, and with a normal eye, that means with no comorbidities, and obviously they were informed about this was a clinical study, and they accepted to be following the ethical board committee approval that we received. We excluded any ocular comorbidities and patients that were difficult because they were with high visual demands, for instance, drivers for night, especially patients that drive trunks, surgeons. They are considered not to be good candidates. I disagree, but this was something that came with the protocol. And finally, let me explain to you how we measure the quality of the retinal image. So far, we have the quality of the image that provides a lens in the optical bench. But we did a study that has been published, as you can see here, in Eye and Vision 2021, in which we have been investigating one model using pyramidal aberrometry to measure in the retina of the living eye how is the quality of retinal image. Look at this paper, we describe it all, and we analyze different types of lenses. You can see here how we get. We're coming from ocular aberrations and from the sterile ratio, we can build up the bidimensional PSF, which is the one that you have here, and the best could be a pinpoint from the distal image to the retinal focus. This is obviously the ideal profile, but if you convolute this PSA value and the sterile ratio, you can get the chart. And the chart is what you have in your right, and tell you how is the quality of retinal image that the patient has. Obviously, neuroprocessing is coming afterwards, but you have a very good quality of retinal image. You can anticipate that the patient will be dealing well, because the patient doesn't need to adapt to halos, to any double image, or any disability that has in the chart. So the visual refractive outcomes were the ones that you can see here. Obviously, this was the one of the Hanita. Please look how is the quality of retinal image for far. This is important. You would see now something more about this fact. And this is correlated well with an uncorrected and bilateral corrected, uncorrected visual acuity. So look here that we have excellent for far minus 0.02, that is more than 20/20, intermediate, very good, and near, excellent. So this lens accomplishes the goal to have far and near vision excellent with good intermediate vision. Not like those lenses that have good intermediate with poor or average near vision. We have good vision for near. This is what we target in our patients with an intermediate that was good enough for the patients. The visual and refractive outcomes are listed here. We were quite happy because we had no touch-ups in terms of refractive predictability. We get exactly where we were. We have to tell that we screw the patients with astigmatism more than 1.5, up to 1.5 we do opposite clear corner incisions. So in this graphic you have which was the result with the Hanita lens and no other correction, not tonicity, only lenses. This is the focus curve. And you can see here monocular and binocular. So here we have very good vision for far, vision for near parallels the far vision in terms of quality, and intermediate vision is really very good and enough to perform a normal light. You have to think that the focus curve can be tricky because you can have this the focus curve but with bad contrast sensitivity, because if the light is dispersed too much among the different foci, then you have a problem with mesopic contrast sensitivity, which is not the case with this lens, because what you see here is the mesopic the focus curve, not the scotopic. Contrast sensitivity, as couldn't be another way, was really good. There was not significant difference between the control and the problems in terms of high cycles per degree, that means in the high frequencies. High frequencies are hypercritical, is when you have the problems at night or when you have the problems in low mesopic sensitivity, and this guarantees that not only the focus curve is good, it is the contrast sensitivity that is good as well in low mesopic contrast sensitivity. Now let me go through patient-reported outcomes. That is really another parameter that we consider today probably the most important, because patient satisfaction, that is the success or not of our surgery. If you look to this data, you have to 1, 2, and 3 measures in 1 occasionally, little, in 2 you have often, and in 3 very often. As you can see here, we had halos in the level 2. So that was important in frequency, but not in severity, that the patients didn't qualify that as that much. Halos are expected to have, and glare as well in the multifocal lenses diffractive. But if the quality of retinal image is good, this event is filtered and is compensated by the good quality of retinal image and the transparency and the quality of the material. As you see, we had as bothersome, which is probably what happens to be more important, where the patients are discomfort because of that. You see that all the parameters are below 1, which that means that is non-relevant at all, and only halos was 1, and none of them were 2 or 3. That means we are dealing with patient-reported outcomes of high quality, leading to high patient satisfaction and excellent outcomes, as I told you. This is the patient-reported outcomes measures. Again, you can see here the different sentences up to 10, in which we were measuring the different performances that a patient can have in different conditions, from driving a car to real world vision, near world tasks, seeing objects close to or poor in dim light. Dim light is the most tricky one that we can have. A look that we have not even one in any one of the parameters, only seeing objects close to you. In poor or dim light was 0.88, so didn't reach the mean, even 1. And in general, you can see that the overall near vision satisfaction was very good, 0.97 over 10. So really good. And over 1 to have 0.97 is difficult to find a lens that really gives to you this outcome. How often the patients need the glasses? 90% never for near, 90% never for intermediate, 90% never for far. So only 10% use glasses for some of the moments, and these were the patients that hadn't been left with some astigmatism that were hypercritical in terms of vision. But patient satisfaction, remember, was 97 over 1. So if we have the patient, the main question, would you select these multifocal lenses again? 90%, obviously all of them that were spectrum independent say yes, they would. And remember, this was not including tonicity. That is something that you have to correct when you're dealing with multifocal lenses. So in conclusion, our study offers to you that the Intensity Pentafocal lens successfully restores all vision range, the full range in presbyopic patients. The flat profile of the focus curve have the 5 foci distribution increasing the depth of focus in a way that you have good vision in all distances, has an excellent optical quality that, in my opinion, is something that you never ask to your commercial on the company. How much is the optical quality and the retina of your lens? They don't know, but this is the fact. We know now, and this is one of the key factors for the success. And what is the profile of my patient now? I'm using this lens since almost 5 years ago, and I like it for especially this group of patients. The intellectually active patient who prioritizes continuous reading and the medium range of vision with excellent far vision, tolerant to minimal dysphotons. And this is a profile so professionals, doctors, surgeons, lawyers, people of high performance that really needs to read, and patients that have highly demanding. Patients highly demanding are for this lens. So don't be aware or don't be careful about the type A personality. Type A personality, those that seems to be aggressive, are the most grateful to you if you accomplish the results in the quality that we have in this patient. And as a summary, the lens satisfies high visual demands. As I told you, we had no complications, and then neuroadaptation failure. Neuroadaptation failure is when you have to decide to expand the lens and to change by another multifocal or refractive. It's never happened in our cases. The minimal amount of side effects typical of multifocal intraocular lenses, I have to add, and this was a parameter that was not included in the study, we never had one YAG laser capsulotomy in these patients during the period of the study. This is important because early PCO makes the patients to be dissatisfied because they don't expect to have another procedure in the first 2 or 3 months, a period in which, as you know, we have the risk of macular edema, and this is something that is due to the profile. Hanita lenses have a very well-known profile for their laser capsulotomy levels, which are extremely low because the profile of the peripheral rim of the lens. This is a paper. You can read what I showed to you in this presentation. In this paper published in 2025 in Eye. It's a prestigious journal, and you can read all the details about patient-reported outcomes, quality of retinal image, patient satisfaction in general, and the performance that we have in terms of refractive outcomes and the other parameters that we have mentioned to you today. In the coming month, our third edition of this book, Multifocal Intraocular Lenses, the Art and the Practice, is going to be released, and you will find one chapter about this lens with other lenses in this book that had, in last edition, 45,000 volumes sold by the company. We have the online clinical course that we have in our university with 300 hours of teaching activities in multimedia and in English, in which we have a full module on intraocular lenses, and you will find it very interesting, especially those that are at this moment in a junior condition or in the residency training. And this Alicante is one of our marinas. It's a beautiful place where multifocal lenses are very enjoyable because we have very good light. Thank you very much for your kind attention. So I'm happy to answer any question that you can have. Yeah.
This way you'll be able to hear.
Thank you.
Professor, thank you. Wonderful lecture as always. I use intensity lens a lot. And what do you do when they complain? It's rare, but what do you do when they complain about halos?
Well, when you have a patient complaining about halos, first you have to look to the refraction. Most probably you have a residual refractive error, might be astigmatic or might be slightly positive, but especially negative is when you have the problem. And then how to test this is just prescribe glasses for a while, and the patient has minimal halos at that moment, you have to treat the residual refractive error. When you have a -1 or -1, there is no doubt. When you have this moderate refraction with about 0.5 diopters negative and a little bit of astigmatism, I prefer to use glasses for a while. The patient can be in the office for a couple of hours reading, looking, or the patient can be just looking through the window, and the patient feels a benefit, you need refractive surgery. Usually in these cases, I do PRK. I prefer not to do LASIK in these cases. But other than this, believe me, it's not frequent. I have not a single case of explantation. The patient should know that halos and glare are something that you have to expect when using multifocal lenses. You have to pay the trade-off of good vision for near or some halos, and the best way to demonstrate the halos is to have a +1 and the patient over whatever refraction the patient has, and then they make a pinpoint in the screen of your projector, and the patient can realize what is a halo. They know what is that, and following that and medical education and certain time a little bit is enough. But my outcomes with this lens, believe me, have been that good that so far, and I am an expert in neuroadaptation, I have published many papers on that, is the one that really have left to me satisfied enough not to have any problem. I really pay attention to the PCO, because early PCO is a problem. Some lenses lead to very good lenses, by the way, to early PCO, and this is very disgusting for the patient, very annoying for the surgeon, because the patient starts not having good vision, but it's too early to make a yard laser capsulotomy because the risk that you already know, and for the patient is not acceptable not to have good vision. You have to deal with the patient to wait and to make obviously a lot of check time with it, not with this lens, as with all the Hanita lenses. I have been using the C lens, other lenses, and yard laser capsulotomy is absolutely ignoring this patient early post-op, and in the late sometimes you have to do it. But it's really something that is related to the design, not to the optics. Thank you for your questions. That's all. Thank you. Thank you.